within 24 hours after the meeting has completed. I'm going to turn it over to Michelle to do the MaineCare introductions, and then we'll move forward through the rest of the agenda.
Good afternoon, everybody. My name is Michelle Probert. I'm the director for MaineCare, and thank you for joining us this afternoon. First, from the MaineCare team, Peter Kraut is going to introduce himself.
Just waiting for my video to start. I don't know why it's not working, but in any event, I am Peter Kraut, the rate setting manager for MaineCare, and I am joined by two of the three rate setting staff, Lori Bailey and Grace Williams.
Great, thanks, Peter. And in addition to Peter and his team, we also have a number of folks from MaineCare Policy here today. We have Henry Eckerson, Carrie Philbrick, and I think I saw Trista Collins as well. There might also be other folks in the greater attendee list from other DHHS offices as well. And with those introductions, I will jump straight into why we are generally here today. Next slide, please. So MaineCare and the department as a whole has been talking about this project for quite some time now, and are very excited to have Myers and Stauffer on board to lead these efforts, and even more excited to have our first round of stakeholder engagement that's happening this week. As you all know, MaineCare is really a health insurance program, and foundational to all health insurance are the rates that we pay for providers to deliver those the services that that our members and patients in general receive, and making sure that those rates are adequate for providers to be able to perform high quality work is essential to ensuring that members have access to care and that they have access to high quality care at that. I will also say that how we pay for care absolutely has an impact on services as well, and that is actually the focus of this first round of stakeholder engagement. And then the system that we have right now, as some of you may appreciate, is really complex. It is at times inconsistent. It is at times confusing. It can be hard for certain services for providers to navigate. It is also very burdensome on the state side to administer our program. So in addition to our objective of having a better system to make sure that our rates are adequate, and also to make sure that the way we pay for services is aligned with getting high quality care, we also have goals for streamlining our system and making it more rational and coherent, which will improve things for everybody all around. Next slide. So as I said, this is our first round of stakeholder engagement this week. And again, we are very much focused on how we are paying for care and would like your input on the impact of reimbursement methodologies on the administration of your practices and services, on the services themselves where applicable, and also potentially on your members. We are going to be having a second round of stakeholder engagement. It is during that second round, which will be in mid-November, where we focus on what we pay versus how we pay. We are going to be, Myers and Stauffer is going to be completing what we've been referring to as a benchmarking report, where we're going to look at all the services that MaineCare covers and compare what we pay and how we pay for those services to what other state Medicaid agencies and Medicare and commercial payers pay for comparable services. And that will help give us an idea of where we might be outliers, both on the high side as well as the low side, in terms of what we pay, as well as how we pay it. And we know that that's not going to provide complete and perfect information, but it is instructive, good baseline information for us to work off from. So we're really excited to get that report. And once we have that report and you all have a chance to look at that report as well, that is when we'll be engaging with you regarding adequacy of rates and access to services. So I wanted to note that we will be taking written submission of comments as well as your comments on the mic today. So if you think of something later or would just rather write things down, that is fine. We'll provide that email address later. And then lastly, again, the purpose of this meeting is really to hear from you. And so we won't, aside from this initial presentation, we won't be responding to questions, and we want to hear much more from you than we will be talking today. Next slide. All right, so if you looked at the discussion questions that we provided ahead of time, you'll note that we have some questions in there about value-based purchasing. And we think about value-based purchasing quite often, maybe on a daily basis, but we know that that's not true for everybody. So wanted to give a little bit of an overview of what we mean when we're talking about value-based purchasing. So the term value is one that everyone uses quite a bit, but we don't often really think about what the definition of value is. And I think that it's helpful to do so. And I like the word value because by definition, it means the relationship between quality and cost. And while it's a bit oversimplistic, I also find it helpful to think about how you achieve higher value with those two levers. And so if you think about holding the quality of a service constant, the way you improve value would be by reducing cost. And if you are holding cost constant for a service, the way that you could improve value would be by improving quality. And obviously there's a lot of different ways in which those things interact. But the point is that we want to make sure that the way we're paying for care helps to incent higher value care, whether that is through reduced cost or improved quality or some combination of the two. And with our fee-for-service system currently, we are not paying for value. We're not paying attention to quality or to cost when we reimburse. We are reimbursing for volume. So the more service you provide, the more you get paid, and it's as simple as that. So we want to move away from fee-for-service because we don't think it's a system that is working well. I will also note that fee-for-service tends to be pretty administratively burdensome and doesn't offer a lot of flexibility for the kinds of things that we know result in better coordinated care and that need to happen when the actual member might not be directly in front of you. You'll all be happy to know that my daughter is waving a red sign at me right now to try to get my attention. I'm on a big meeting, go away. Reality of remote learning. Okay, so, excuse me. The door is shut now. So MaineCare does have a number of value-based purchasing initiatives currently, and we have a specific goal we're working towards. Right now, about 20% of what MaineCare pays is related to value-based purchasing efforts, and we have a goal of doubling that percentage to 40% by the end of 2022. Next slide. So another phrase that you will hear from us is alternative payment models, or APMs. And APMs are really a means of how you get to value-based purchasing. There is a great organization called the Healthcare Payment Learning and Action Network, or HCP-LAN. Their logo is on the bottom of the slide here. And they've done a lot of really great work over the past number of years of convening stakeholders across the country and coming up with common terminology and common definitions about what we mean by alternative payment models and how we define those different ways of paying for care on one end of the spectrum, starting with fee for service, category 1, where there's no link to value, as I stated, and then going along the continuum all the way to a population-based payment, which is very flexible, where there is obviously a lot of accountability for cost as well as quality of care in those models. So I encourage you to check out HCP LAN. And the nice thing that they also do is on an annual basis, they ask different payers to report on how their payments fit into these categories. And so you can see how Maine compares to the rest of the country. MaineCare reported on this last year and is planning to report again this fall. And so it's a good way to measure progress on a nationwide basis. All right, so that is my little spiel. Again, thank you for joining this afternoon. I am going to turn things over back over to Julia, and she will walk you through the areas of discussion that you'll be engaging in today, as well as some of the housekeeping rules and how things will proceed. I am unfortunately not able to stick around, but you've got lots of other folks from MaineCare and from the department, and I very much look forward to hearing about and reading your input. So thanks a lot.
So the slide in front of you is the overview of the 5 questions that we're going to ask. We're structuring them around 30 minutes per topic, but we will go faster or slower based on the amount of comments we get per question. You can advance to the next slide. We're going to be using the hand up method of signaling that you'd like to speak. If you're looking for the hand, it looks kind of like a little hand, but it tends to be left of a symbol that looks like a megaphone, which might be easier to spot. It's usually above your chat bar, but it could be, depending on how your WebEx is laid out, it could be somewhere in one of the panels. If you cannot find your raise hand button, then you can chat at us in the chat box, and Jillian will be able to see that, and she will be able to unmute you at the time. Our role is really to introduce the discussion questions and kind of manage the time and the flow of the conversation. We also, like I said before, we have recording this, and there will also be a transcription provided at a later date. Your role is to really to introduce yourself and the services that you provide, so we can associate your comment to the right services. Stay focused on the relevant topic that's being discussed. If someone has made a lot of points, it's perfectly fine to say, I agree with that person's points. And again, we're limiting this to methodology, payment methodology, and not payment rates. Go to the next slide. So the recording will be online again within 24 hours. Phase 2 will be the time for, like we had said before, the second round of stakeholder engagement, which you'll be able to comment on the phase 1 report, and there will also be discussion of rates. And as always, you can submit any written comments to us at ratesettingeval@maine.gov. We'll give the email address again at the end of the meeting to make sure that everyone has the opportunity if you aren't able to speak. So our first question is trying to understand how the current methodology is working for the services that you provide. So do you feel that the payment methodology is transparent and easily understandable? Does it create opportunities for you to be efficient in the way that you provide your service? And does it reflect how you deliver services? So if you typically do a bundle of services, do you have to bill separately for each one? Do you have to bill in 15-minute increments for a service that is typically provided 1, 2, or 3 hours, for example, and where it may be more burdensome to have a 15-minute increment? So if you would like to give a comment, please use the raise hand, or use the chat box if you're not able to find the little raise hand button.
Okay, I am not seeing any hands or anything in the chat box right now. Here we go. Here's our first commenter, Gwen Simmons.
Hi, can you hear me?
Yes, we can.
Okay. Hi, I'm a physical therapist. I am representing the Maine chapter APTA. I kind of wanted to hear what everybody else had to say about this one. I've actually gone round and round in my head with it to try to figure out really how to respond. Initially, my thought was that assuming that the methodology is based on the Medicare RBRVS formula, which is a little bit difficult to tell from my analysis if it really is, then that's the formula that providers are used to seeing and using. We're used to billing with that methodology as well. It is essentially a 15-minute code for PT and OT services, at least for the codes that we use the most, which are the timed one-on-one codes. But as I started thinking about it, if there's an opportunity to make it easier and more efficient, I think that we could support that. The problems with the coding system as is with the different intervention codes. A lot of them are very similar to each other. They overlap in some ways. Under the Medicare system, we have to bundle those minutes. So there's modifier codes that are supposed to be added on to codes, and sometimes they get added on to the wrong code, or they don't get added on at all, and it creates a situation where either the code is kicked out or it's denied, and then it requires an additional administrative time to try to get that resolved, and that's on both the provider end and on MaineCare's end. And if you really look at the reimbursement rate that you pay for each of these different intervention codes. So let me give you an example: therapeutic exercise, neuromuscular reeducation, therapeutic activities, and manual therapy. Those are all 15-minute codes commonly used by PTs that are like within $1 of each other. So it would make a lot of sense to simplify things and have one particular code and have it the same rate, providing the rate is adequate enough. And that's going to be the key to everything that you guys decide. Likewise, I think visits tend to be 30 minutes, 45 minutes, or 60 minutes. More commonly, probably the 45 to 60 minutes, particularly in the area of pediatrics. If there were an opportunity to have a per visit code, providing again that it's adequate enough to cover our costs for 1 hour of services, that would be ideal, because then we don't have to try to sort out in the provider's head, how many minutes of this did you do and how many minutes of that, and what do you, how do you bundle, and if you do bundle, what code do you charge? It would, sort of simplify things. Sorry for the ringing of the phone in the background. Anyway, where else was I going with that? Did I address all of your questions with that? Yeah, I think so. So in my head, it's really difficult to separate out the methodology from the adequacy of the rate. I know that you don't want us to comment on that, but everything gets back to the adequacy of rate, including whether you can even address value at all when the reimbursement is 30% or maybe 50%. It's not more than 50% of our cost to provide the service. You're not going to be able to improve the value because we can't afford to do anything for lesser cost. And I think that's what is driving this whole need to review the rates in the first place. Yeah, in summary, I would support a payment method that was more simple, providing it's adequate, and also, and this is maybe jumping ahead, but providing that it enables private practices to still see MaineCare patients. So some of the discussion that, or the questions that you're asking about value-based purchasing, I'm not sure where that fits in to the patient who, for instance, a pediatric patient who needs ongoing PT and OT services, sometimes for years, for developmental problems, and they're, they don't need to necessarily be seen by hospitals, for instance. And I'm not sure what you mean by value-based, if you're talking about paying one rate for an entire episode of care, or paying one fee for whatever providers are seen. And those models might work good for some services, particularly if somebody has to have surgery and then they have to have the follow-up care afterwards. But in the patients that we're seeing on an outpatient basis, I don't think those methods of bundling payments are necessarily going to work or be the answer. And that's all I have. Thank you.
Thank you, Gwen. Next up, I have Jen.
Hi, yes, this is Jen Corbeil, basically referring to under 21-year-olds when we talk about when we're talking today, because I run a pediatric practice and we deliver occupational therapy, physical therapy, and speech therapy services. As far as the transparency of the current payment methodology, I would say that it's not transparent. I mean, and kind of reiterating some of the things that Gwen Simons just mentioned. I mean, we really tried to dig into this a couple years ago, and we had a bill to try to increase the rates for some of the rehab codes. It was really difficult to figure out where is this rate coming from? What is it based on? Is it a percentage of Medicare fee schedule? It just seemed very arbitrary. We couldn't really figure that out. As far as being understandable, sure, it's understandable that it's $12 per CPT code or whatever it might be. It's so hard not to talk about the rate, I'm sorry. But it's truly does not appear to be transparent. I guess I'll leave it at that and wait for phase 2. As far as efficiencies and economies, I mean, we work with children under 21 years old. Is there efficiency in that? No. We don't necessarily have to worry about bundling. We bill by the 15-minute code for both OT and PT, but when it comes to speech, it's untimed codes. The challenge with that is that we need to create a separate facility to bill for speech therapy services, and that has been created a lot of challenges for billing timely reimbursement because of that. Just looking at the rest, I kind of answered all the questions, and so I'm trying to look through my notes based on each question here. I think that covers this one right now. Thank you.
Okay, thank you, Jen. Okay, I am not seeing any other hands up or anything in the chat box for this question.
Okay, great. We can move to the next question then. So what we're really asking here is, do you believe the payment methodology is creating the right incentive or perhaps creating a disincentive that supports quality of care, access, primary and preventative care, the integration of care coordination, how members use services, and is the methodology structured in a way that it avoids abuse and fraud? And go ahead and put up your hands again if you would like to speak, or chat at us in the chat box if you can't find the hand.
Okay, first up I've got Jen.
Hi, Jen Corbeil again, mainly focusing on under 21-year-old PT, OT, and speech. The cost of delivering care it's really challenging to hire experienced providers to deliver this service, so that impacts quality of care. If you're consistently not able to hire somebody in order to meet the needs of what it costs to deliver this service, impacting the quality of care that these MaineCare recipients are receiving potentially, because they're not getting the highest quality therapist or provider because of that. There's also an issue with access to care because of the rates currently. Many outpatient clinics, adult outpatient physical therapy clinics have wait lists. That's an issue of access, and that's just because they can't afford to deliver the service to MaineCare members. Sometimes you have to make really challenging decisions when you're running a clinic on who will get that appointment, based on some of these challenges that occur under the MaineCare system. As far as coordinating care, there's really no way to bill, especially under 21-year-old care right now when we're talking about pediatrics. There's no way to bill for a lot of the coordination that we do when we're doing letters of medical necessity for a stander, for a gait trainer. There's no way to recoup that cost. As far as members using this service, I don't think I have anything to say about that. And when we're talking about access issues, that's huge. I mean, we're talking about children that have, a diagnosis of cerebral palsy. If they don't sit before 2 years old, the research shows us that there's a good chance that they won't walk. So if there's a delay in service, that's a big deal. That really impacts their outcome later in life. And then when we talk about adults, same thing. If you have an adult that comes in with back pain, if they can be treated through physical therapy means, that can avoid costly surgeries. So access is really a huge issue. Thank you.
Okay, thank you, Jen. And next up I have Gwen.
Hi, I hope Jen and I don't hog all the time here. Sorry about that. I only have a couple things to add to what Jen said. And again, it's really difficult to separate the adequacy of the payment from the methodology here, because it's the payment adequacy that's creating most of the problems. Regardless of what the methodology is, the access to care for the clinics that see adults, a lot of them have to limit how many MaineCare patients they see, simply because they can't stay in business if they take too many MaineCare patients at one time. So they do have to put people on waiting lists, or the patient has to go somewhere else. But in addition to that, and I don't know if anything can be done about this, but the cancellation rate for adults who have MaineCare is extraordinarily high. So many clinics just don't want to even schedule those patients, because the chance of them canceling might be as high as 50%. And you can't, in that situation, you get no money instead of the 50% of your cost covered with the MaineCare reimbursement. If there's anything that can be done about that, I don't know what those problems are, if they're related to MaineCare patients not having transportation, but that probably needs to be investigated. Otherwise, in terms of integration of care, I think the payment mechanism, it shouldn't be, I guess care coordination maybe and integration are kind of overlapping in my mind, but in terms of if what you're talking about is whether the payment mechanism influences how providers communicate with each other, or whether they communicate with each other, to some extent, I feel like that's a professional responsibility of the treatment team, no matter what the payment mechanism or methodology is, or who the provider works for. So, it shouldn't, the care should not have to be within one system for all services in order for professionals to talk to each other when they need to coordinate care. And then lastly, in terms of fraud and abuse, we don't even need to talk about that until payment is adequate, because I can guarantee you that no one's going to overutilize services so that they can get paid half of what their costs are. So, again, that's not really a payment methodology issue so much as an adequacy issue. And where the payment's not adequate, you don't even have to worry about whether you're incentivizing fraud and abuse, because you're just not incentivizing that at all with the low payments.
Okay, thank you, Gwen. Okay, I just wanted to mention that we are getting some comments related to the speakers as they're talking in the chat. So if you agree, you can also type a quick comment in the chat, and that will be also saved. Just wanted to mention that. Next up, I have Ryan.
Hi, my name's Ryan Gallant, and I run 3 pediatric clinics in central Maine. And I just wanted to speak to the quality of care and access to care. And it's, again, not so much the payment methodology, but in terms of the inadequacy of the rate. But we continually are having issues with keeping our therapists on staff. We have had numerous therapists leave the state simply because they can't afford to work outpatient pediatric services due to the rate. All of our private payees pay us, well over double of what the MaineCare rate is, sometimes even triple of what the MaineCare rate is. And our therapists simply just cannot afford to work in the state of Maine at that rate, when they can leave and go across the border into New Hampshire and Massachusetts and make double the money so they can pay off student loans and whatnot. So again, it's more the rate is what I'm speaking towards, and how it's impacting quality of care and access to care. Thank you so much for letting us speak towards all these topics. I think it's really important that you're having us involved. Thank you.
Okay, thank you, Ryan. I'm not seeing any new hands or requests to speak in the chat. So
we'll go on to the next question number 3. So this one is a little bit tricky, but it's really looking at, if you had to look across your service area at the providers and services provided by other provider groups, would you say there's equity in the payment methodology? Are fee schedules determined and updated in an equitable way? Is the administrative burden fairly equitable? Are the incentives equitable? So go ahead and raise your hand or chat at us if you would like to speak on this.
Okay, first up, I've got Jen.
Hi, Jen Corbeil, PT, OT, and speech. The rates are not equitable. That's clear when you look at other sections. And again, the methodology for setting the rates is really puzzling as well. But there are sections under the MaineCare system that reimburse a lot higher, and then there's other sections where maybe there might be a higher level of education or a higher level of licensing needing to deliver the care, but yet it's reimbursed at a lower rate. So it's not equitable at all. I would also say, well, we've talked about this, but I would just reiterate, that it's difficult to understand the current methodology for setting rates for each section. And then when we're talking about hospital outpatient settings, that's very different with their reimbursement and how that is set. Well, the reimbursement compared to outpatient settings from a private practice perspective. And again, not equitable at all. As far as administrative burden, I'm just looking at all these questions again here. Make sure I keep my, so as far as administrative requirements and administrative burden, I mentioned earlier that to deliver speech services that we need to have a separate facility, and there has been just a whole slew of issues with that as far as billing goes. Sometimes having to manually enter 100 visits at a time because of billing issues and not being able to wait for reimbursement. So that's been really challenging, and often when you reach out to support, that's what the answer is. Well, enter it manually on the portal, which is not doable for practices at all. We are also chasing authorizations from primary care physicians. This can lead to an access issue. So if a child's on our wait list and we're waiting for that prior authorization from the primary care physician, we're chasing that around, and we just can't afford to do that to have that level of administrative burden. It's really, really difficult to deliver the service. Thank you.
Okay, thank you, Jen. Next up, I have Gwen.
Hi. Just to add to what Jen said, I agree with everything she said. First of all, looking at the current fee schedule, I put all of the reimbursement rates on a spreadsheet and compared those to Medicare's fee schedule for 2020. And the fees are ranging somewhere between roughly 30% to 52% of Medicare's current reimbursement rates. So the numbers are all over the place, which is what supports what Jen said, that it doesn't appear that it's based on Medicare's methodology, or if it is, then it maybe was based on the formula years ago, which has changed over time. So there is no clarity on that. But with regard to the fee schedules being updated, I would really encourage you to somehow set up a system, if you don't intend to wait until statute is passed before you are forced to update the fee schedules all the time. Set up a system so that we can at least get some kind of cost of living increases every so often, and so that it won't necessitate a need for different providers to go to the legislature every time they need to have their reimbursement increased. And I think that's the reason why we have some of the inequities already, because other providers in the past were successful going to the legislature and getting their rates increased, where if the provider group did not ask the legislature to increase their rates, then they were stuck with the same low rates, and that's what happened to PT and OT services. Again, I would encourage you to kind of look at that and try to set a system up that we can routinely have the fees at least evaluated and updated for cost of living. Thank you.
Thank you, Gwen. Let's see. Ryan, do you have your hand up, or is it still up from last time?
I apologize, it was up from last time, but I will mention one of our biggest pieces that we see as a concern is to frequency in terms of how the rates are, how they're reviewed and how often they're reviewed. I know we provide several other services, and they are seem to be reviewed and at least discussed at the state level, at least annually. Whereas I think like OT and PT, it's as the previous caller had mentioned, it has been several years since I believe those rates have been even brought up as a concern. So again, the frequency of the review would be important. I totally agree with that. Thank you.
Okay, thank you, Ryan. I'm not seeing any more hands up or any new comments. Julie.
Okay, so we can move to the next slide. So this is question 4 and 5 that we're kind of doing together. So is the methodology consistent with some type of value-based purchasing, or consistent with any other value-based purchasing approaches that you have seen or have been in place through other payers? And then secondarily, to this, are there administrative requirements related to coding, billing, and reimbursement? that MaineCare specifically places on you that you feel are burdensome.
Okay, I'm not seeing any hands up or comments on this question. Okay, I've got Gwen.
Just to address the question you asked about, is it consistent with any other value-based purchasing approaches we've seen in place with other payers? Actually, in the outpatient arena, we haven't really seen any other payment methodologies that were specifically related to value-based purchasing. And maybe I just don't have a really good idea of what you mean by that. We've seen things like flat fee per visit methodologies and caps on either amounts or number of units charged in a visit, but nothing that I would call a value-based payment methodology. And maybe Jen can jump in and say if she has seen any of that with other payers. I have an opportunity to review a lot of payer contracts because I'm a physical therapist and a lawyer. So I just haven't seen anything like that in any contracts that I can think of. So yeah, that's the only thing I would add about that.
Okay, thank you.
Oh, wait, I'm sorry. Can you still hear me?
Yes, we can.
I forgot to mention one thing that I have heard complaints about, and I'm not sure if it fits in with this question or not, but there are some issues with, and maybe Jen already spoke to this, there are some issues with when MaineCare is the secondary payer, that the MaineCare does not get the, I guess, the electronic bills from the primary payer, and so there's a lot of extra work that has to go into trying to send the EOBs from the primary payer to show what was already paid. And maybe if Jen has not talked about that, she can jump in there, but that's probably the biggest administrative burden that I've heard complaints about.
Okay, thank you, Gwen. I've got Jen.
Hi, yeah, I'm not, this value-based purchasing just has me puzzled. I mean, where the way that speech and PT and OT is reimbursed is fee for service. And without talking about the rate, I just don't know that I can say much more else about that. But in regards to, and I apologize because previously I'd answered this question about the administrative burden. The billing issues with when MaineCare is secondary, so typically under like a Katie Beckett program or something like that, there's a lot of issues with that where the MaineCare, the EDI, the system doesn't currently allow for providers to just bill automatically electronically, that you do have to go in and do that manually, especially for speech. For some reason, there are a lot of issues with speech billing. So it's quite costly to deliver the service when you're having to have that additional administrative burden and administrative cost as well. So yes, that is true what Gwen mentioned. There's challenges with billing MaineCare secondary, and often it's honestly not worth the cost for doing it and just increases your write-off, unfortunately. Thank you.
Okay, thank you, Jen. Gwen, did you have another comment? I see your hand still up. Okay. I'm not seeing any new comments or chat.
Okay, you can move to the last slide. So at this point, we want to remind everyone you can submit any written comments to us at ratesettingeval@maine.gov. I'll also open it up briefly because we have some time, and just ask if there's anything you feel like is really important for us to know before we go into writing this report that you haven't already had an opportunity to talk to us about. We just want to give you this opportunity to let us know any information that you think is important for us to have.
Okay, first up, I've got Ryan.
Yes, just one of the things in regards to administrative burden, at least for us, there's typically a significant delay in credentialing therapists when we bring people on. So, I mean, I think we've gone 3 to 4 months when trying to credential somebody at times, being a huge delay in terms of cash flow. So if that could be addressed somehow, that would be a significant improvement for us.
Okay, thank you, Ryan. Oh, excuse me. Thank you, Ryan. Next up, I've got Jen.
Hi, yes, thank you. I just wanted to mention that it's the website, the MaineCare website it's really difficult to locate information. It takes lots and lots of searching to look for fee schedules and that kind of thing. And it's not just me. Like, I know I've heard from others as well. Looking for the billing manual. It's really difficult to locate information. I thought I would just add that. Thank you.
Okay, thank you, Jen. I'm not seeing any, oh, I got a hand up from Gwen.
Yeah, first I want to say thank you for giving us the opportunity to provide input. But I had a question about the process that you're going through. I believe Ms. Probert said you were going to be somehow collecting rates that private payers pay. What's the plan for how you're going to collect that information, particularly when some of those at least the commercial rates are confidential contracts that are going to be difficult to get information on?
This is Julia. So we do use databases that have that information on generally commercial payment. I'll say it's not always necessarily associated to the specific commercial payer, but there is specific commercial payer information in databases that we can access. We're also comparing similar services to other state Medicaid programs. So we're trying to find as many usable and meaningful benchmarks to provide context for what the rates really it's most useful for identifying rates that are outliers, ones that are very low compared to a broad spectrum of benchmarks, and ones that are very high compared to, if that exists, compared to the broad spectrum of benchmarks.
So you'll probably be using the comparemaine.org data, I'm sure, from the all-payer database and Medicare's fee schedules.
Yeah, those are typical data sources that we would look at.
Yeah, the input I would give you about just I guess as baseline to look at, Medicare rates tend to track with the very minimum that a practice can afford to take, just because they're so close to the cost to do business, if that helps you. Also, just to let you know, if there's anything we can do to help you find any information, we're happy as the PT Association to try to do that to the extent we can provide you with meaningful information that you can't otherwise access and that is not the subject of a confidential contract or something. So, please use us as a resource for sure.
Okay, thank you, Gwen.
All right. Well, thank you, everyone. I want to remind you, don't forget about our email address. If there's anything that occurs to you later that you think is important for us to know, or if you know someone who was not able to join us this afternoon and would like to provide feedback, we're happy to accept it at the ratesettingeval@maine.gov email address. Thank you all very much for taking the time out of your afternoon to come and speak to us. We very much appreciate it, and I hope that you have a lovely rest of your day.